His Eminence Prime Minister, Eminences, Venerable monks and nuns, and colleagues and friends, thank you for inviting me and for the chance to say a few words about an interesting topics of the dialogue between contemplative practices and psychiatry, psychotherapy on the other side. Meditative and yogic practices are both central to all contemplative practices, to Vajrayāna Buddhist tradition as well, and are methods that contribute to man's search for balance and health, both physical and mental. In their original contexts, religious and philosophical traditions, they were not primarily meant as healing practices, but practices for establishing equilibrium, psychophysical and psychosomatic, clearly not unrelated to health on all levels, and insight into the mechanisms on man's path to spiritual awakening. In Vajrayāna medicine and psychiatry, they are founded precisely on such mind and body interactions with ultimate medicines, if we call them, in compassion and emptiness, which are, through the practice of Dharma, aimed at eradicating etiology in root causes of greed, hatred or aversion, ignorance or delusion. And we know that Buddhist diagnostics of delusions is much more strict than the usual psychiatric one. Right? We are all delusional unless we are liberated. And I try to apply these methods also for myself as a patient first, and then I try to apply it for others. Nonetheless, the insights from these practices, in spite of their main spiritual scope, have trickled into medicine and psychiatry and psychotherapy. They can be jointly explored within the conceptualization of contemplative psychotherapies or transpersonal psychotherapies, as we have heard before. We can trace a long history of interest of leading psychotherapists in contemplative practices. We have heard of them cited several times: C.G. Jung, E. Fromm, Abraham Maslow, Edward Podwall, and many others. Some of them had a long-lasting relationship with respected masters of contemplative practices. We know from Fromm that had a long relationship with Nyanaponika Thera, and Edward Podwall with Chogyam Trungpa, and Howard Custer with His Holiness the Dalai Lama. So the use of contemplative practices, that we can also. We have been just here. And the use of contemplative practices, meditation and yoga, in contemporary psychotherapy has faced a strong research impetus. From the year 2000 onwards, it's really exponentially going. I will just briefly go with you through some important areas of research. First is chronic pain syndromes. Meditative practices are beneficial for improvement and self-regulation of chronic pain, be it in several disorders like fibromyalgia, endometriosis, and also somatization and functional somatic disorders. These are disorders that are very often treated in medical practices. Then we have existential anxiety, if we call it, all the patients with cancer and other severe disorders, also cardiovascular disorders like infarction and post-vention of it. So the practices of meditation and yoga have given good and beneficial help in establishing tranquility, finding purpose in life, decreasing levels of anxiety and depression, and improving quality of life. Also, for example, in women with breast cancer, in patients with cardiovascular diseases, and others. Then there is a huge field of depressive disorders, a huge impact of what depressive disorders do to us and to our society. And meditation and yoga has been studied extensively. Individual studies and meta-analysis have shown that it is very beneficial for the treating depression and preventing relapses of depression. Then we have anxiety disorders, also a variety of disorders that can benefit from contemplative practices. There are again analysis and meta-analysis showing that from different anxiety disorders, it can patients can get great profit. Then psychotic disorders, even if some clinicians are a bit skeptical, but there are many studies showing that also in psychotic disorders, it is a safe and beneficial practice, meditation and all embodied practices. Then addiction disorders, also a huge problem, where reduction of craving and prevention of relapse is a benefit that can stem from contemplative practices. Sexual disorders and eating disorders, especially the overeating, compulsive overeating and bulimia nervosa. So in clinical practice, be it psychiatric or psychotherapeutic, inpatient and outpatient, we can work with contemplative practices. We can work on two levels, be it that we integrate the insights from these traditions into our everyday practice, what can be called as a contemplation-informed practice, or on the other hand, we can directly induce or introduce these techniques to our patients. Why it is so important that the knowledge, the experience and expertise of these practices are there for psychiatrists and for psychotherapists. It is first because patients search and need contemplative practices. They do it by themselves, not through us. And as therapists, we do not have a choice whether our patients will go for them or not, but whether we have an ear for that, whether we listen to these practices and accompany our patients with it, or we indulge the safety of selective inattention, to call it that way, to just ignore it. Secondly, through contemplative practices, patients autonomously practice between the sessions. They gather lots of psychological material and can bring it to us through that practice. Thirdly, contemporary psychotherapy, we face a lack of body awareness and sense of what the illnesses and problems do to our body. So it is, again, a chance contemplative practices, namely, introduce and compensate precisely for this lack. Its primary entrance point for majority of them, and we can really follow and accompany our patients in that. Fourthly and lastly, contemplative practices are embedded in their respective religious and ethical frameworks, and that's they rise and fall, we can say, with ethical concerns, and ethical concerns is what we need in psychotherapy to a great extent from the beginning and throughout the process. So if we take a look into mechanisms at work, we can see that there are many good mechanisms and ways, strategies, how we can apply these practices. We unfortunately don't have time for more precise or detailed presentations. We can perhaps talk about them. So in our hospital, that's the hospital in Ljubljana where I work, we conduct groups and individual sessions with patients, both in and out patients. We offer first a psychoeducation or an education of these practices, meditative, yogic, and relaxation practices. Then patients themselves choose if they wish to know them better and to start practicing them on a regular basis. Then we can design a program for them, and we further accompany and follow them up. with clinicians or by clinicians who are versed in contemplative practices. Just a few reflections. There is no doubt that we face a lively and increased interest in contemplative practices within contemporary psychotherapy. We have witnessed, and we still do, many new formats and packages of these practices for medical or therapeutic purposes, from transcendental meditation to mindfulness-based packages. The good side of such pragmatic, manualized, and decontextualized or recontextualized in another context, these applications is their translatability into research designs. And we have much more research as we have ever had in this field, as we witness also in this conference. Evidence is a good base for clinical applications and for designing new research. However, we should not forget that the original sources of contemplative practices and to read from the original contexts, because otherwise too much will be lost in translation. The theoretical dialogue between contemplative practices in their primary homes, be it Vajrayānic, Theravada psychology, or Christian contemplative tradition, and the major psychotherapeutic paradigms from psychoanalytic to existential and transpersonal is for now weak, under-researched, and sometimes misleading. It is and would be if better developed a prevention of reductionism, of unethical conduct, of disorientation and loss of connection with values. In severe decontextualization lies a danger of the further uprootedness of the already uprooted individuals as we meet in our patients and as we many times ourselves are. To conclude, we can conclude that meditative and yogic practices, even if they were not conceived as primarily therapeutic practices, have considerable therapeutic potential for many mental disorders. Renowned Franco-American psychiatrist and neuroscientist David Servan-Schreiber listed them among evidence-based treatment methods for overcoming stress, anxiety, and depression. There are many ways how to introduce, integrate, and follow these practices in contemporary psychotherapy. Some of them are problematic, unethical, and misleading. The cure and prevention of these dangers is a thorough, systematic, and enduring study on theoretical and practical level, with clear awareness of traditional roots of these practices. In the dialogue between the two traditions, that is, between the over 2,500 years of contemplative practices on one side and the only 120 approximately years of contemporary psychotherapy, the latter could be humbler and the former louder. Vajrayāna medicine and psychiatry, as we have seen above, founded on mind and body interactions, as we have heard, is one of the important parts of it. And the conferences like this are an important tools in the spread of traditional knowledge and thus of good guidance and preventative measures against negative side effects mentioned above. Thank you very much for your attention.